Uh, Bismillahir Rahmanir Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everybody, for this Keratoconus instructional course. Welcome all to this session, and it's a great honor and pleasure to have Professor Paulo Vinciguerra with us, and Farhad Zafizi as well will join us later. Both of them are renowned names in the world of keratoconus diagnosis and management. So I'm sure that we are going to learn a lot from them tonight, and there will be a very good discussion. So I will start with my presentation first, which is about the diagnostics and monitoring. Great. So usually diagnosis of keratoconus should go through many steps. It's not like just topography and that's all. It starts with eye examination, refraction, detection of scissoring reflex, then going to some investigations such as tomography, epithelial mapping, biomechanics, and most recently the biomarkers when they are going to be available in the market. Of course, when we talk about eye examination, it's very simple examination of the slit lamp where we can detect focal thinning, which may be inferior, characterizing the pellucid marginal degeneration. For example, sometimes we can detect vox striae in advanced cases of keratoconus. We can see the hydrops cornea. We can see corneal scars, Manson size and sign and Risotti sign. We can detect them very simply as well. Then we go to the refraction. We have to have a doubt about any ectatic corneal disease in case of non-optimum vision. For example, if the best corrected visual acuity is not 20/20, then we have to have a doubt. Why is that? Maybe it is irregular cornea. When there is unusual high with the rule astigmatism, high oblique astigmatism, against the rule astigmatism in young people, because usually against the rule astigmatism is found in adults, and when there is an isometropia, especially in children. The scissoring reflex is very simple to detect, and I usually do it for every patient coming to my clinic, regardless I'm going to do refraction or not, just to detect if there is any scissoring reflex. And actually, it has been shown by this very nice study, published study, that the retinoscopy as a screening tool for keratoconus is a very effective tool with high sensitivity and specificity. What are the tomographic features and classification of ectatic corneal diseases? Actually, before we study the tomographic features, we have to be sure that we are using the standardized settings, and then we validate the captures to avoid any factors of false findings. You have to be aware and not deceived by thin or steep cornea, because sometimes thin and steep corneas are normal. And you should not be comfortable when you see symmetric or thick cornea, because some kinds of ectatic corneal diseases may have symmetric and thick corneas. Always think of previous corneal refractive surgery when you find any irregular cornea. Very quickly, I categorized the ectatic corneal diseases into 3 categories to make it very easy to detect and to give a name to what you see. The first one is the established ectasia, including keratoconus, PMD, PLK, keratoglobus, and post-laser vision correction ectasia. The second one is the paraectasia, including 2 expressions, the keratoconus suspect and formed frost keratoconus. And the third one is cornea with higher potential to develop ectasia if we do corneal refractive surgery, which are posterior keratoconus and apparently normal cornea when there is family history of keratoconus. Very quickly, we say there is keratoconus if the anterior curvature map is abnormal and posterior elevation map is abnormal, regardless of the thickness map, because sometimes we may find thin cornea but normal. We say it is pellucid marginal degeneration when there is crab claw and there is bell sign on the thickness map. The bell sign characterizes the inferior band thinning in the cornea, as in this case. We say it is pellucid-like keratoconus when there is the crab claw pattern, but there is no bell sign on the thickness map. We say it is keratoglobus when there is generalized steepening and generalized thinning extending to the limbus. The post-laser vision correction ectasia may mimic any of the previous entities. The para-ectasia, two very similar expressions indicating anterior curvature abnormal, other maps are normal. Whenever we find this and the other eye has frank keratoconus, we call this abnormality as formed frost keratoconus. But if the other eye has no ectatic disease, then we call this keratoconus suspect. So it is just the same abnormality, but depends on the other eye. Posterior keratoconus, everything is normal except the posterior elevation map. However, it may be due to congenital deformity, especially if it is bilateral and associated with scar. We come to the epithelial mapping. It's important because it helps us understand the behavior of the epithelium in the ectatic diseases. It may take the focal thinning pattern, the inferior superior asymmetry, radial thinning, or generalized thinning. So whenever you see any of these patterns, you have to have a suspect of keratoconus. We come to the biomechanics. Let's say the father who started the field of biomechanics was David Luce, who invented the aura in 2005. And based on the aura, we could, in the very, let's say, early years, those years, to find some cases and exclude some cases when we find some flattering after the second peak, for example, or the peaks are very low. Then the software developed in order to give further, more parameters and even the probability index as well. Then the Corvus came in 2011. After that, there was a very nice work thanks to Paulo Vinciguerra, Cynthia Roberts, and Renato Ambrosio for the great work they did. And Paulo Vinciguerra in 2016 came with a very important index, which is the TBI. It's a very helpful one, and we can, according to that, detect any changes in the cornea. Very recently, in 2016, Rohit Shetty came with the tier biomarkers for keratoconus, and he proved that the keratoconus is an inflammatory disease rather than the old definition as non-inflammatory disease. Now, how to detect the progression? There are 4 ways, actually. The first one is the Bellin ABCD keratoconus staging. The second one is corneal biomechanics. The third one, epithelial map. And then my own arbitrary method in case you don't have such wonderful technologies. The Bellin ABCD keratoconus staging can give you a stage because it depends on the radius of curvature around the thinning area for both anterior and posterior corneal surfaces, in addition to the corrected visual acuity, and can monitor progression and stage it to you. Corvus, the biomechanics, is a wonderful tool as well, because when you compare the follow-ups, it can give you that the cornea is getting softer or it is just stable. Dan Reinstein was the first to describe the epithelial mapping, and he classified the stages according to the epithelial mapping. He has his own machine, ultrasound, high speed, and the own classification of the epithelial mapping. According to Dan Reinstein, that progression of keratoconus and ectatic disease is associated with thinning of the epithelium over the cone and thickening just above, in the area just above the cone. The arbitrary method is to do 3 captures per visit by the same observer and compare the medians, in addition to do precise refraction and compare the astigmatism. There are 4 variables. The first one is a change of Kmax more than 1.5 diopters, thinning more than 15 microns, and those numbers just to avoid the noise of the distorted cornea and the machine. The third one is a change in the magnitude of the astigmatism, subjective astigmatism, of course, more than 1.5 diopters, or a change in the axis more than 15 degrees. So any 2 of the 4, any change in 2 of the 4, then we can consider there is a progression. Of course, this is very, very rough way, but you can use it just in case you don't have the technologies. However, we have to pay attention to how to observe the cornea after cross-linking. We can start observing the cornea after cross-linking just after 6 months. During the 6 months, you have to forget the cornea. You cannot decide whether there is a failure in the cross-linking and whether there is progression of keratoconus, because the K readings change during the first 6 months in the same way of progression, and the thickness thins during the first 6 months, very similar to the progression. So during the first 6 months, the cornea will behave as if there were progression. So we have to forget it and start the monitoring at 6 months onwards. Thank you very much. Now I would like to invite Professor Paulo Vinciguerra to present. We will listen to the recording.
Thank you for the kind invitation. I would like to start with my disclosure. These are my disclosure. Well, in the past, some corneal pathologies that has been treated with corneal graft can now be successfully be treated with therapeutic excimer ablation. Why PTK? Is that today a substitute for therapeutic keratectomy? No, because we have less adverse events, it's possible to modulate the result, it's faster functional restoration, it is a refractive surgery. We have no immunological reaction, reduced risk of infection, astigmatism, post-op greater resistance can be repeated, and is an attempt to postpone eliminate a corneal transplant. And if it fails, you can do always other surgery, but not the opposite. So let's move from the standard PTK that we have.
This is the presentation of yesterday.
Dear team, would you please stop
from therapeutic ablation.
Dear team, would you please stop?
Which are the indication? The indication is whenever you have aorta aberration of the cornea, superficial dystrophies on corneal superficial opacity. Contraindication when you have ectasia, endothelial pathologies, dry eye, hostile self-deficiency or glaucoma. It can improve the visual quality if we set the treatment priority with respect to the available tissue. So first priority is high order aberration. The second is cylinder, opacity and sphere. You can see that the font text size is diminishing to highlight which is where you have to place your importance. Opacity versus irregularity, and opacity is often compatible with a good visual acuity. A slight irregularity is not. When the irregularities on surface are removed, the residual opacity is reduced over time. Let's see an example for it. A ground glass is completely transparent, but you cannot see anything. With sunglasses is not transparent, but you can see a sharp view. And let's see another example.
There's another presentation for this session for Dr. Paulo. Please be careful of what you are sharing, please.
Sir, the team, COIC team, please. Are you with us? Hello, COIC team, are you with us?
Yes, sir.
Please speak.
All right. So would you please play the correct presentation of Professor Vinciquera? Hello? Anybody with us?
If you couldn't, don't be embarrassed to delete, because I fully understand that you have a time schedule to respect. Don't worry.
No, of course, we need to learn from you, Professor, but I don't know why this technical problem. COIC team, excuse me, anybody with us?
Sorry for that. We're trying to fix now. I'm apologizing, Dr. Paolo and Dr. Mazen. Sorry for this.
Thank you. No, it's not this one.
Not this one, sir.
You have two. This is one.
So,
you have another one.
No, I don't have, sir.
Okay, so would you please allow Professor Paolo Vinciquera to share his screen, and would you please kindly, Professor, present the presentation?
Yes.
Thank you very much. Thank you very much.
I have done a lot of paper on collagen cross-linking that are listed here. And we was involved in the phase 1 resident study and phase 2 that was used for the CE mark in Europe to allow the cross-linking to be performed in Europe. And we was a small group of people with Dr. Colena, Ladan Azuri, and there's Professor Frucht and Frue and Conan and a few others. Sorry, we have done this study based on 660 patients, and that is the group. So globally, we was more than 1,000 eyes, and that is all the case that was treated in terms of follow-up in term. First of all, that is the visual acuity. One interesting point that the visual acuity is constant improving over time. So don't worry if you do not get immediately the perfect outcome. Something very important that also the achieved correction in terms of spherical equivalent have a constant improvement. Now that we have even more years, we have up to 10 years, we see a constant improvement and flattening. The best corrected visual acuity also improve over time, so don't worry about that. And you can see that the longer the follow-up, the longer is the increasing of the best corrected visual acuity. Then we do a study to separate pediatric patient between 18 and 28 years old from 39 and 39 and more than 40. And that is the visual acuity for group. And the spherical equivalent over time, you can see that we have observed in average 1.6 diopter of change, while surprising, the astigmatism did not change. Why this is so? And the spherical equivalent is consequence because of that. Because mostly do not improve the astigmatism, because what improves is the coma. So the reduction of coma transfer the coma in terms of astigmatism, regular astigmatism. You can see example for it. Also key 1 and key 2 get an improvement. Also the topographical index get improvement over time. That are all the topographical index, the sign, the SRC, and the total aberration was improved over time, particularly in the long-term follow-up. Now, let's see also the biomechanical. The mechanical improves so much over time. We did not at that time all the index that we develop now. So we are not able to show you much more than this, but we have improvement of basically the deformation amplitude in 1 millimeter with respect of the general deformation amplitude. and the highest curvature radius improved so much. Also, in terms of the other biomechanical parameters improved so much. So also, we did also a study also with the aura, and also the aura shows improvement over time. Just scrolling quickly, because we have a lot, that is the aura study. We see that the main change is that we have a very weak peaks before, and after we have almost a normalization of the second peak, showing that is great improvement biomechanically. Now, let's see something that can interest you much more. The change in best corrected visual acuity over time in terms of age. So, most everyone improves, but let's see something more in detail. The older improves less than the younger. That is very important. And the loss of best corrected visual acuity lines, very few, was more in the age between 18 and 29 years old. The one who mainly, in the group who mainly remain unchanged is the over 40. That is clearly because we have a natural cross-linking in older patients. And let's see something more. The change in best corrected visual acuity over time. That is the change at 6 months. That is at 1 year. Now at 1 year, the figures change a little bit. Still, we have more people gaining line between 18 and 29. And gain also the older patient. So the older patient takes more time to improve, even if patient who lost one line, that is 15% in the general group, was mostly located in the older patient. If we look at 24 months, we see that the lost line decreased from 15 to 7. So the lost line is very few, but you see now reversing. The patient that still lose some line are the younger one. That is explainable because it's the more aggressive, in the long term, the more aggressive keratoconus show that. Now, let's see by curvature group. So the patient who improves the best corrected line change over time by curvature group. So the patient who gain more are the patient that lose more, they are more steeper. So when you have patient with a relative flat cornea, you can expect more gaining in terms of lines. The spherical equivalent change, you should expect a larger change in spherical equivalent in patients who have the highest curvature, more than 50 diopter. The spherical change over time, or you have located or in the patient with less than 45 or over 50. The astigmatism is changed more in the patient who has the highest curvature at the baseline. Now let's see the change dividing patient by pachymetry. The best corrected acuity line change over time is almost identical, even if we can see that at the 12 months, the patient who gain more is the patient who are the thinnest cornea at the baseline. The spherical change over time by pachymetry, we can see that the flattening, the greater flattening we have in patients who are the thinnest group. And the astigmatism over time is better, the change, improvement is better when the pachymetry is more than 450 micron. The spherical equivalent change over time is greater in the thinnest group. Now let's see something about transition, the demarcation line. As you can see, we can obtain different depth even for the same protocol, because at the time was the standard Dresden protocol. So why this is so important? Because what we find out that the patient who's starting with the thinnest pachymetry have during the suction, the soaking time, the huge thinning of the cornea. So the irradiation become deeper in the long term because they start with a very thin cornea, becoming even thinner with during the soaking time because the destran. Remember something, if you do a very thin cornea, why we leave the safety level 300 micron? 300 micron should not be, to me, a limit. You should measure the pachymetry before of irradiation. So 300, I will suggest even be more prudent, 340, 330 micron before the irradiation, because you can have a cornea that is 480, and after the soaking time become 290. You can get surprised. We did measure it because we do the cross-linking under our Schwind system, who has a OCT based inside of the system. So we can measure during the treatment. And that is what happens if you do the cross-link in a patient who have a very thin cornea before of the radiation. You lose endothelium, and that is when you irradiate a cornea without the thinning. So remember that you can have also in the long term some complication, particularly if you do not do the calibration, the focusing, and you do not verify the focusing constantly. And that is what happens if you are too close to the eye. So the highest irradiation is the periphery. And remember, if you do that, you do not have haze. You have a deep opacity that is very close to the endothelium. Remember that in PRK is a completely different haze. It's superficial, so very easy to ablate and fix it. In the cross-linking, you cannot ablate. And this deep opacity stays over time. The stria, if you have these stria immediately after, let's say 1 week, 10 days after, you should expect a larger flattening over time. These are the cornea who get flatter over time. The thinning after the surgery is only temporary because riboflavin contains the striatum, the collagen fibers and lamellar packet, and because the epithelium takes time to do this. So you should wait for weeks. And remember, that is the figure. You start with this keratoconus, and over time you have a constant flattening and a huge improvement that is concentrated in the area where is steeper. It's not homogeneous flattening. It's concentrated where is useful. And also the change in best corrected visual acuity is respectful with the pachymetry and the tangential maps, because you should look at the true net power, take in consideration what is the posterior surface, because sometimes the anterior do not change so much and the posterior increase so much. And remember that reduction of the pachymetry over time needs to be followed, because these are lamella packet, is not progression, because this is not related to increase. The cornea becomes thinner, but not steeper. Something that I already mentioned, over time, the astigma, the coma is transformed, is a regular astigma. This is why do not change so much, but improve so much the visual acuity, because it's moved from a coma to a regular astigmatism. And that is shown on the wavefront maps. So look all the examination to be sure to do not be scared by something. And something, the last sentence is that, remember, the patient that after cross-linking, if the demarcation line is deep enough, the still progress, always still rub the eyes. So the first question to ask for to a patient that is still progressing after cross-linking, do you are still rubbing your eyes? If yes, you have an explanation. And that is the first cross-linking meeting in 2005 and the friends that built this. Thank you very much.
Thank you very much, Professor, for the comprehensive and very nice overview. Now, let's see if any of the audience have questions so far. I can't see any questions in the box. Okay.
Thank you, everyone.
That's great.
For
Yeah,
listening
thank
to
you
me.
very much,
And
Professor.
thank you for the invitation. Arrivederci.
Thank you. So now, team, please. Yes. I think Professor Farhad is not with us, but did he send to you the recording of his session?
Yes, sir, we have the recordings.
Yes, Doctor.
So would you please, yeah,
Can you please share?
please play that.
Hi, this is Farhad Zafizi from the ELSA Institute in Zurich, Switzerland. My topic is office-based corneal cross-linking. Now, these are my financial disclosures. Let's look at the origins of corneal cross-linking. It all started clinically in Zurich in 2002. 5 years before, Eberhard Spörl and Theo Seiler have published a seminal paper in German language in 1997 in Der Ophthalmologe, speaking about the concept of cross-linking. And as I mentioned, in 2002, we were treating patients in Zurich, and this is a well-known epi-off procedure. It was the Dresden Protocol at the time. And we also created the very first irradiation device, which was the UVX1000 by IROC. And at that time, as you can see, CXL was not called CXL, but CCL. We later changed the name to X-linking and finally to CXL. Cross-linking, the way we know it, has been performed in operating theaters in the laying position throughout the world. But if you think about the fact that only a small fraction of the global population has steady access to such an infrastructure, and at the same time every ophthalmologist on this planet has a slit lamp, then the idea was born to transfer the entire CXL technology from the OR to the slit lamp, and I would like to show you why this is possible in an effective and a safe manner in the next minutes. The device I helped constructing is the CI device by Imagine, produced by CSO Italia. Here you can see the CI device in full use at a slit lamp, and you see how steady the patient is. So you can use the machine on any type of Hawk Stride or Zeiss type slit lamp. There are more than 30 models that can be fitted. But if needed, you can also use the device on a table mount in the laying position like I do here in a young patient with Down's syndrome under general anesthesia even. The CI device carries a large number of keratoconus protocols, keratitis protocols, and even refractive ones. And we have validated many of the well-used protocols. For example, the famous 9 minutes, 10-minute epi-off protocol has already been validated fully also in the sitting position. And as you can see here, you see a very nice demarcation line that is just as deep as you would expect it in the laying position. Another important element of cross-linking at the slit lamp is the fact that the sub 400 protocol that we published earlier last year in the American Journal of Ophthalmology is fully integrated in the machine. For those who are not familiar with the sub 400, our group invented swelling of the cornea, hypoosmolaric riboflavin, 15 years ago to treat thin corneas. But the sub 400 protocol is the future of treating thin corneas because it doesn't unspecifically swell. It rather adapts the total energy to the patient, to the individual thickness of the patient. And this makes much more sense than just swelling the cornea over 400 micron. As I said, we published the results in the AJO in 2021. And now you can treat corneas as thin as 200 micron of stroma with different various levels of fluence. So if you have, let's say, a cornea that is 280 micron thin, stromal thickness, then you know that you need these many minutes at 3 milliwatts to reach a depth of 210 micron for the demarcation line. You can download a preprint of this article free of charge via our foundation's website. And as I mentioned, the sub 400 protocol is fully integrated into the CI device. So thickness, and it's the thickness you determine at the end of riboflavin installation. It's an epi-off protocol, and then you can treat right away. The sub 400 protocol gives because we can treat down to 200 micron of stroma, and this made it possible for the very first time to even treat keratoglobus. And this is published in the Journal of Refractive Surgery Case Reports journal. Yet another element, and a very, very important element for cross-linking at the slit lamp, is epi-on. Cosimo Mazzotta published this very nice paper using pulsed UV light, high fluence, gentle acceleration, and he could do a very effective epi-on without additional oxygen. You don't need goggles, you don't need any oxygen boost, because the combination of these factors allows for enough oxygen in the cornea at all times. But Cosimo Mazzotta still needed iontophoresis. This protocol, the technical settings of the irradiation, are also present in cross-linking at the slit lamp in the CI device. And my research team spent another year at the Swiss Federal Institute of Technology to get rid of the iontophoresis part. So now we have epi-on without additional oxygen, without iontophoresis, just a lot of drops and light. In other words, no more iontophoresis needed. Let's switch to keratitis treatment. What is new? Something very exciting is new. We published the results of our prospective randomized phase 3 trial where we compared only cross-linking for keratitis against only medication. And guess what? In ulcers up to 4 millimeters of bacterial and fungal origin, we are just as effective as medication. One single puck cross-linking treatment as effective as a week or 10 days of constant medication. Again, you can download the open access article here. The future will bring even higher total energies. This trial was performed at 7.2 joule, and we published laboratory data showing if you go above 7.2 joule, if you go from 7.2 to 10 joule and even to 15 joule, then you hit 100% of efficacy, for example, for bacterial killing. And also a much higher efficacy for fungal killing. Look at this example of a 6 millimeter fungal keratitis that we treated not with Dresden protocol, not with 5.4 joule, but with 14.4 joule, almost 3 times the total energy, and this is the result. Some obstacles had to be overcome. When establishing cross-linking at the slit lamp, we need to make sure about the question we always ask, Doctor, will the riboflavin go down with gravity? The answer is yes, it will go down, but you have 60 minutes of time before it is noticeable. And that's by far enough time to perform cross-linking. Another question is, what about fixation at the slit lamp? Well, my answer is, let's look at these videos. The lower video is running. The only reason you see it running is the flickering of the screen. The patient is totally stable. Now I will switch on the upper video. Again, very nice fixation. See this fixation light? This is for the other eye. So the patient has a very steady fixation target on the other eye, and this helps tremendously. So fixation is really not an issue. The patient is comfortable because we need 4 minutes for puck cross-linking. We need around 10 to 12 minutes for the various Keratoconus protocols. And as you can see, one very good trick is to give the patient the doctor's chair with the armrest, so they are really comfortable. This is my procedure room. This is not a sterile OR. And in the meantime, we don't cover the patients anymore. They just wear a mask and a hat, but no more sterile gowns. What about infection risk? Well, my answer is you can do cross-linking at the slit lamp for keratitis because the patient is already infectious. And for keratoconus, once we are fully in epi-on cross-linking and the transition is coming now, there is no infection risk. And even in epi-off, the risk is extremely small. I will now publish my case series of 511 consecutive cases in the office without any infection. And please don't forget, our retinal colleagues are even switching intravitreal injections into the examination room, not in the procedure room, into the examination room. So this is totally feasible for cross-linking. We have published the technique of CXL at the slit lamp in the JRS last year. And this is what you see when you look through. Centration and finding the right distance is very easy. All you need to do is to focus on the cornea, on the apex of the cornea anterior surface. So this works very nicely, and it is in clinical use now in more than 60 countries. So in other words, cross-linking at the slit lamp, in my eyes, clearly is the future of cross-linking. It democratizes access to CXL technology, and it is suitable for all epi-on, epi-off, keratoconus and keratitis protocols. Please follow me on Instagram for further updates.
Thank you very much, Professor Farhad, for this very nice presentation and information. If any audience have any questions so far? I cannot see any questions in the question and answer box. Okay. Dear team, can you show me the timetable? Any remaining presentation?
Hello, this is Farhad Zafizi from the ELSA Institute in Zurich, Switzerland. And my topic is, I would like to present you a new accelerated epi-off cross-linking protocol that is just as strong as Dresden protocol. These are my financial interests. Now, if you think about the cross-linking procedure, then we know that you need light, you need riboflavin, and you need oxygen. The fact that oxygen is needed is known since 2013. It was my group that published a paper doing a very simple and I think elegant experiment. We performed cross-linking under a hood here. That's a plexiglass hood with a helium atmosphere, no oxygen, and then we had no increase in stiffness. So 100% dependency on oxygen. And then 1 year later, we published this paper here on the right-hand side in IOVS. This is showing the stiffness with Dresden protocol and the stiffness with 9 milliwatts 10 minutes, 5 minutes at 18 milliwatts, and so on. So we showed that only the Dresden protocol gives the strongest stiffness. And I will now explain to you why. Watch this video, this single slide, and then you will be perfectly fine understanding all these different factors and how all these different factors play together to influence the cross-linking procedure. Now, these factors play a role in epi-off and epi-on. Let's concentrate on epi-off for now. So this is the slide I was talking about. What do you see? First of all, you see a bar with oxygen, and green would mean enough oxygen for good cross-linking, red would be bad. Same thing here, enough riboflavin for good saturation, and red would be not enough riboflavin. This here may happen in epi-on, but usually in epi-off cross-linking we always have enough riboflavin. It is rather a problem of the oxygen. And what you see up here is a simple bar saying this is a very good success for cross-linking and this is no success at all, biomechanics. Now, when you look at the Dresden protocol, which is 30 minutes at 3 milliwatts, the combination of 30 minutes, this is 1,800 seconds, times 3 is 5,400 millijoule or 5.4 joule. This is the fluence. That's Dresden. If you do Dresden protocol, then you have very good cross-linking success because you have a lot of oxygen in the cornea. It's a slow protocol and you have enough riboflavin. Now what happens if you accelerate? Look at the bars to the right. Look here. You see that time goes down, intensity goes up. 10 minutes with 9 milliwatts per square centimeter. The total fluence here is still the same. What happens with the CXL success? It is still very good, but it goes down a little. I know we use this protocol in most of our adult patients, but when you have a child, you often go back to Dresden protocol because it is even more reliable and efficient. Why? Look here. Because if you accelerate, you have a little less oxygen at this position. And if I go even faster, if I go down to 5 minutes at 18 milliwatts, still the same total fluence, then the success will go further down because you have even less oxygen at this position. And finally, industry made a mistake here more than 10 years ago. If you go very fast, 3 minutes at 30 milliwatts, well then you don't have any cross-linking success because there simply is no oxygen left anymore in the cornea. The process is too fast. Now it took us 2 years of intense laboratory research to find a protocol that is just as good as Dresden, but still accelerated. And what we found is we can go a little faster, we can go down to 9 minutes, but we have to give not 3 times the intensity, but 6 times the intensity, almost 6 times. What happened is we went down to 9 minutes, 15 and 18 milliwatts. And this combination is not 5.4 joule, it is much more total energy. It's 10 joule per square centimeter. And by doing so, we keep the same efficacy because by doing this, we have enough oxygen at this position and the high fluence compensates for the relative lack of oxygen. We published this protocol in TVST in 2021. And what we did is look at a total of 300 eyes ex vivo, all epi-off cross-linking, all using RiboCare 0.1% riboflavin for 20 minutes. And we had control eyes, we had standard cross-linking, and then the various accelerated protocols. And what is interesting now, the results I mentioned is, this is the stiffness of a control. This is a very good stiffness of Dresden protocol. And now, just like 8 years ago, we published that if you go faster with the same fluence, you lose efficacy. You can go even a little faster, even by compensating for the fluence, you lose efficacy. But here, 18 milliwatts for 9 minutes, you are just as good as Dresden protocol. And this is the one that we have established now. You have 140, sorry, you cannot see this. My image is covering the graph, but it would say 144%. And Dresden protocol is 138% of stiffening, so a very good effect. So in conclusion, epi-off cross-linking can be accelerated from 30 minutes to 9 minutes 15, and you maintain the same biomechanical strength. As you have seen, the laboratory data have been published. We are currently finishing our clinical validation study, and we will submit the paper in the next months. And then you will have a full integration of this new protocol into the CI device at the slit lamp. And it will be a free upgrade. So imagine the company behind the CI device will give free upgrades for these new protocols coming to market. If you want to learn more about these newest developments, please subscribe to my Instagram channel. Thank you for your attention.
Thank you, Professor Farhad, for this very informative and the new method. Actually, this will make it very easy for us to go for such a quick and keeping the same efficacy. I think we have finished the presentations, but we still have 5 minutes for questions and answers. So may I ask the team whether there are any questions and answers, because I cannot see in the books any questions. So would like to thank everybody, would like to thank the speakers, and would like to thank the audience for their attendance, and hope to see you physically in Al-Qasimi next year, inshallah Rabbil Alameen. Assalamu alaikum wa rahmatullahi wa barakatuh.